So welcome to the 23rd Mahamana case discussion series. And we have a topic for differentiated thyroid cancer today. The case will be presented by Dr. Gurpreet Singh. He is an research resident in surgical oncology. And we have Professor Gauri Pantavaidya. She is a head and neck surgeon at Tata Memorial Centre, Mumbai. Professor Krishna Kumar Thankappan. He is a head and neck surgeon at Amrita Institute of Medical Sciences, Kochi. And Dr. Shikhar Sahni, who is a consultant head and neck surgeon at Apollo Hospitals, Lucknow. We shall be starting the case now.
Thank you, Aseem, and thank you, KK and Shikhar, for adjusting. I'm sorry I had to leave a little early. Thank you very much for joining in early.
No problem.
Shall I start? Good evening, respected teachers. Myself, Dr. Gurpreet Singh. I'm first year MCS resident in surgical oncology department in Mahamana, Pandit Malviya Cancer Center. So today I will be presenting a case of differentiated thyroid carcinoma. My patient is a 30-year-old female, resident of Chitran, Uttar Pradesh, and housewife by occupation. There are no comorbidities, and patient is having no addictions. She presented to us in the OPD with chief complaints of swelling over the right side of neck since 3 months. On further asking for the history of presenting illness, patient complains that she noticed the swelling around 3 months back. Before that, she was apparently all right. She noticed the swelling and it was insidious in onset with gradually progressive. Without any history of any pain associated with the swelling or any rapid increase in the swelling. There is no history of difficulty in swallowing or tough while swallowing or breathing difficulty or change of voice. There is no history suggestive of any hypothyroid or hypothyroid features. There is no history of any radiation exposure in the past, and there is no history. There is no significant history of medical illness or surgical interventions in the past. On asking the person history is normal. The menstrual and obstetric history was found normal with 4 days of menstruation with 30-day cycle. With the patient gave the menarche at the age of 14 years. She is married with 2 children. The last month of last days of menstruation is 28th of August. And there is no family history of any similar illness or malignancies in the past in the family. Sorry. Shall I proceed with the general examination?
No, go back to your history, Gurpreet.
Yes, ma'am.
Yeah, go back to the first slide.
Yes.
Okay, do you need anything else on your history for, so you have said it's a swelling over the right side of the neck since 3 months. What do you mean by insidious in onset?
Means it is was found on a sudden was not chronically progressive disease. It was sudden in onset.
So how did the patient find the swelling?
She noticed herself when she was having shower in the work bathroom.
And in 3 months it's progressing, is it?
Yes, ma'am.
So what does that signify? If a thyroid swelling progresses in 3 months, what does it signify?
Thyroid swelling which is progressing within 3 months indicates towards malignancy, while the benign lesions they cannot progress at this much of rate.
And a papillary thyroid cancer will increase in size in 3 months, is it?
Not very sure, ma'am. Other papillary around, not very sure, ma'am.
Okay, so first of all, papillary thyroid cancers, most differentiated thyroid cancers will also not progress in 3 months.
Okay.
So a progression in 3 months probably indicates a high-grade malignancy. So you have to get this history very carefully. You can't just write gradually progressive. Most thyroid nodules, unless they are present for maybe 5 years, 6 years, 2 years, 3 years, will not progress in size.
Okay.
Okay, so this history is extremely important, because if I know that there is a progressive thyroid nodule in 3 months, either this patient is having a very aggressive malignancy, so you must understand, and that aggressive malignancy will constitute only 1% of all thyroid nodules, or less than that also.
Okay.
So what percent of solitary thyroid nodules are malignant?
In women, the 5 to 6%.
Can't hear you very well. Can you turn your head to the mic? Yeah, yeah.
Hello, yes, ma'am.
Yeah, yeah.
Okay, okay. So around in women, around 6 to 8% of solitary thyroid nodules are malignant, while in males, the risk of malignancy is lesser. It's around 1 to 2%.
Correct. So now you have a solitary thyroid nodule. In that, the risk of this patient having malignancy is very low. In that, having an aggressive tumor which increases in 3 months. So please be careful whenever in a thyroid case presentation you talk about progression of the nodule. It has great implications. Okay.
Right,
Most thyroid nodules will not progress in 3 months.
right,
Okay. So be careful when you use that.
sure.
Yeah. Go ahead. Next slide. Krishna Kumar, Shikhar, you all want to ask some questions?
Gurpreet.
Sir, good evening, sir.
Yeah, Gurpreet Shikhar here.
Nice. Good evening.
Yeah, so you said swelling on the right side of the neck. Can you be more specific in your history, whether the patient presented with a complaint specifically on the right side, or was it more towards the midline, just going towards the right? The reason why I'm asking is, do we go straight towards thinking about like a thyroid swelling, or is it like a lateral neck mass?
Right, so on asking the history of presenting illness, patient was explaining that it was just slightly towards the right side of the neck, not extreme right. It was just slightly towards right side of the neck.
But it was like a midline swell, like a parameter swelling. You mean to say, is it?
Right, sir.
Yeah. So okay, yeah. So then we'll go and think about thyroid swelling to begin with. That was what I wanted to ask.
Okay, sir.
Yeah, go ahead, KK. Go ahead, KK.
Shikhar, what is the importance of family history in anterior neck swelling?
Some syndromic associations of differentiated thyroid cancers we can rule out by asking the family history.
What sort of syndromic associations?
Like the familial adenomatous polyposis, or the Cowden syndrome, or Carney complex. These can be ruled out.
Okay.
What about
All right.
thyroid cancer?
Yes, ma'am. Should ask about thyroid cancer also. Can be medullary, which can run along the families.
What thyroid cancers will run along the families?
Medullary thyroid carcinomas.
Papillary thyroid cancers?
Yes, ma'am. Papillary thyroid carcinomas can also run along families. If there is a germline mutation in the PIRA for red genes.
So red gene mutation will cause papillary thyroid cancer?
Red gene mutation will cause more towards the folliculars of man.
Okay. So what percentage of papillary thyroid cancers are familial?
I'm not sure about the exact percentage. I'm sorry.
Okay, so extremely small percentage of papillary thyroid, irrespective of whether you have BRAF, is not something that is genetic. That does not cause it. Okay, so a very, very small percentage of patients of papillary thyroid cancer will have familial. Which thyroid cancer is more common to be familial?
Follicular is more common familial.
Other than follicular, that's also not common, but other than follicular? Have you heard of medullary?
Yes, ma'am. Medullary is more common. Sorry.
Wonderful. So medullary thyroid cancer. So familial history is basically more for medullary. What percentage of medullary thyroid cancers are familial?
Less than 10% of medullary thyroid carcinomas are familial.
It's actually around 20%. Around 20% of medullary thyroid cancers are familial, while 80 are sporadic in nature. Okay. I'm going to give you a little bit of tip on how you should be presenting and formulating your history. And I do this each time. See, when you ask for your history, you'll give your history of presenting symptoms. That's correct. After history of presenting symptoms, you must go to history of etiology. Then you must have history of complications, and then the other general history to understand the well-being of the patient. Okay. So when you're going for thyroid history, first presenting symptom, you said insidious in onset and you said progressive, which I have my doubts about, but never mind, you that we discussed. Then you're going to come to history of etiology. So tell me, what are the etiologic factors for thyroid nodules?
Radiation, history of radiation exposure,
So
and
what kind of radiation exposure? Everyone asks this question. I have still to find one patient who's got thyroid cancer because of maybe Krishna Kumar may have found more patients. Tell me what kind of radiation exposure, and do you really see this? Where will you see? In which groups of patients? Which states? Where?
history of radiation exposure is more relevant in pediatric age group, because the mental radiation or the radiation exposure in children, though it causes the malignancy after a pretty long time, around 10 to 15 years after the radiation exposure.
So it's not in pediatric. No, the radiation may have been received in a pediatric age group, but you're absolutely correct. It generally occurs many years, 10 to 15 years after exposure of radiation. What kind of radiation is this? High dose, low dose? What kind of radiation causes thyroid cancers? Where is the commonest thyroid cancers that you have heard of because of radiation exposure?
Chernobyl.
Chernobyl. So in Chernobyl, how did they get the radiation exposure? Were they given high dose radiation?
It was
Right. So what happened in Chernobyl, that there was a nuclear disaster and then there was radiation flying all over in the air and people got small doses of this radiation. Okay, so when you have small doses of radiation, it's not at high doses. When you have continuous small doses exposure of radiation, that's when you will get thyroid cancer. Now, small doses of radiation exposure are rare. Any states in the country you know where you may have radiation exposure, low dose radiation exposure?
States which are having the nuclear
Correct. So which states?
the Tarapur and one is in Visakhapatnam, West Bengal. One is the West Bengal also.
So Kerala has, okay, Kerala has, I think it's seen in the sand. Maybe Krishna Kumar can tell because I think he must be seeing a high incidence of these kind of tumors. Do you see it, Krishna Kumar?
Yes, in Kerala, the southern part of Kerala, we're supposed to have radioactivity in the beach sand in the coast of Kerala. So that is one cause for prolonged low dose radiation exposure. What sort of occupation can be related to, chronic radiation exposure? And we occasionally see such patients.
The clock makers who are at a receiving end of radium exposure, or
in our practice, radiographers and working in the radiation oncology department and all those things.
Especially people who are doing interventional radiology. You have radiologists who are doing interventional radiology who don't, if they don't wear your thyroid, after prolonged many years, they sometimes develop thyroid cancers. Okay. So you put in we talked about radiation exposure. Any other family history we discussed? Any other causes of thyroid nodules?
Gurpreet, ma'am, if I may interject.
Go ahead, Shikhar, whenever you want.
Yeah, Gurpreet, madam said that usually you're prone to thyroid malignancy whenever you're exposed to low dose of thyroid, low dose of radiation, and not high doses. Why do you think that is?
He didn't know that answer. You'll have to ask me, Shikhar. I only gave that answer.
The penetration of high doses are more deeper, while the penetration of low doses are superficial. And thyroid being a superficial gland can absorb more.
So it is expected that in a low dose exposure, there is sub-lethal or subclinical damage to the thyroid cells, and that causes mutations which may alter the genetic makeup. Whereas in a high dose radiation, it might not be a sub-lethal damage; it will completely destroy or ablate the thyroid tissue, as we have seen in when we see patients coming back in a hypothyroid state after receiving radiation for other cancers. So, yeah.
So I think great points on low dose versus high dose radiation. It's low dose because they cause mutations. High dose will destroy the thyroid follicles. So they don't cause. High dose radiation does not cause. Any other causes of thyroid nodules? Quickly, we need to move ahead.
The iodine deficiency may cause the.
Excellent. So you have to ask if they are from the. Your history of etiology. Always think history of etiology, then history of complications. Then you will think of what history to ask from a patient. Okay. So your presenting symptoms have to be very well described. What happened? How did it grow? Didn't have anything? Did the patient all of that? Then you go to etiology. Then you go to a history of any complications. So I see you've asked for difficulty in swallowing, cough while swallowing, breathing difficulty, and change in voice. Can you tell me why you asked and what this indicates if the patient had said yes?
The difficulty in swallowing, I was suspecting if the lesion is, if there are compressive symptoms from the lesion. And if the change of voice, I asked because if any recurrent laryngeal nerve involvement is there, to rule out the RLN involvement. And the difficulty breathing can be asked to rule out one, the compressive symptoms, and second, the invasion, the tracheal invasion, or the
Great. So basically, you're trying to look at aggressive thyroid cancers.
Right.
Okay. So what percentage of patients have aggressive thyroid cancers? So what percent of thyroid cancers will you find all these symptoms? And what are the commonest structures which are involved because of an aggressive thyroid cancer?
Commonest structure is strap muscles.
Excellent.
Second commonest is recurrent laryngeal nerve.
Okay,
And,
that's correct. Then
after that, third commonest is
there are only 2-3 structures remaining now next to the thyroid.
esophagus. And
That's less. Before that, before the esophagus,
is tracheal invasion.
trachea, correct.
And
Then esophagus, and last is larynx.
larynx.
Okay. So very of all the thyroid cancers, less than 2 to 3% patients will have any of these symptoms. Okay. That's all I want to ask in history. Anybody else?
Yeah, I think he can proceed.
The general examination, the patient is conscious, cooperative, well-oriented, time, place, and person. The echo status is 0. Patient is averagely well nourished in BMI 27. There is no parietal stenosis clubbing. The pulse and blood pressure are normal. All the systemic examinations felt normal. On looking at the clinical examination now, on inspection, it was a right thyroid lobe and thyroid gland. So there is a right side of thyroid swelling, which is approximately 4 by 3 centimeter in size, moving with the deglutition and not moving with the tongue protrusion. And extending from the extension of thyroid swelling is from the level of cricoid and from the thyroid cartilage to the level of cricoid, and from midline to the anterior border of sternum vestibule. The overlying skin appears normal. There is no any scar, sinus, or the swelling is on palpation. All the inspective findings are confirmed. There is swelling of around 4 by 3 centimeter over the right thyroid lobe. There is swelling is non-tender, hard in consistency. There is no any local rise in temperature. Getting below the swelling is possible, and there is no cervical lymph nodes palpable. Trachea was central, and on fiber optic examinations, both the vocal cords are mobile. On summarizing, she is a 30-year-old female with solitary thyroid nodule of approximately 4 by 3 centimeters in size, hard on the right side of the thyroid gland, the right lobe of thyroid gland. Patient is clinically euthyroid status. There is no any lymphadenopathy and no any compressive symptoms, most rarely of neoplastic etiology.
Why do you say the patient is clinically euthyroid?
There are not any signs or symptoms of hyper or hypothyroidism.
What are the signs and symptoms of
For
hypo and hypothyroidism?
the signs of and symptoms of hyperthyroidism are the sweating, palpitations, and intolerance to heat, and loss of hairs, and the lean patients are usually lean, hypothyroid patients, and for hypothyroidism, they are thick hairs with intolerance to cold, while cold and clammy hands with maybe critical edema.
What did you say
No
last? No eye signs. Okay. And why are you saying it is probably of a neoplastic etiology?
Looking at the progression, it's in 3 months the swelling has increased to this much, and then there is swelling is hard, and looking at the swelling is hard and the progression is fast.
When do you think the thyroid nodule is more of a malignant nature? What are the clinical signs of an aggressive thyroid malignancy?
The clinical signs of aggressive thyroid malignancies can be the invasive features like the cord palsy, and along with the breathing difficulty causing the tracheal invasion, or the skin involvement, or the esophageal involvement. Local invasion and rapid progressive size can be the signs.
Okay. Anything else?
Yeah, go back to your examination findings. Okay, so this is a midline swelling or a right-sided swelling?
So, slightly right side.
Okay, yeah. Now, I think the important things, there are 2-3 important things which I don't find over here. Yeah, okay, you have written that it's possible to get below the swelling. Okay. Now, is this extending to the cricoid cartilage? Because I think it's going further down. I'm not sure whether your examination findings are okay.
This one, actually, the
Okay.
getting
Yeah.
swelling.
So my only the reason why I'm saying I'm not trying to nitpick on things. The reason what I'm trying to say is when in an exam you're presenting anything, now you have to be absolutely perfect. You cannot just write something down or present anything. Okay, so be sure of what you're presenting. If you're going to be sure that what you're saying is actually what is there in the patient. Okay, so take a little effort for presenting it properly during an exam, because you know your examiner will unnecessarily otherwise ask you very small questions. Okay, now tell me, is there any issue with What is the which levels of lymph nodes did you check?
I checked the lateral groups of lymph nodes, the level 2, level 3, and level 4. And also I checked the level 5.
Okay. Is that the commonest site of spread of lymph nodes?
The commonest site, yes, ma'am. The lateral group of lymph nodes, level 2, 3. 3 and 4 are the commonest sites. 3 and 4 are the commonest.
So let's say for a papillary thyroid cancer, the commonest site is level 3 and 4, is it?
So lateral group, ma'am. Otherwise, the most common is the central group.
Correct. So when someone asks you what is the commonest site, you have to say level.
Level 6 and 7.
Yeah. So level 6 is the commonest or the first echelon of lymph node spread. Can you get lateral lymph node spread when you don't have central lymph node spread?
Yes, ma'am. In 20% of the cases.
In 20% of the patients. Okay. In 20% of the. Okay. That's all I have to ask in examination.
What would be the kind of tumors or the location of tumors wherein you get lateral lymph nodes spread first before a central compartment spread?
More the superior lobe or the posterior lateral tumor.
You were right the first time. The superior pole tumors.
Superior.
Yeah.
Okay, go ahead. Did you present the BP and pulse rate?
Yes, general example.
Okay. What is the importance of BP in a case of thyroid?
So BP may be altered because of the thyrotoxic or hypothyroid features. In thyrotoxicosis, the BP is generally low, while the hypothyroidism, the BP is generally high.
Any other reason where patient can present with hypertension? Any other association?
In medullary thyroid carcinoma, because of the involvement of the adrenal gland, patient may present with the hyperthyroid. The high blood pressure.
What is that condition called?
Pheochromocytomas.
What did you say?
Pheochromocytomas.
Pheochromocytoma. Okay. And what's the importance of pulse rate?
The importance of a pulse rate is in hyperthyroid patients. The pulse rates are usually towards higher sides.
All right. Great. Okay, go ahead.
On thyroid function examination, the patient was euthyroid.
Before you go ahead, I just want to ask you, suppose I say this is a papillary thyroid cancer, what is your TNM stage?
For this patient, the TNM stage will be T2 and 0M0.
What is T2? Tell me. What is T1? What is T2?
T1 is less than equal to 2 centimeter of the tumor without any extrathyroid extension.
T1 has any sub-classification?
T1A and T1B less than equal to 1 centimeter, more than 1 centimeter to less than equal to 2 centimeter.
Okay.
Then T2 is more than 2 centimeter to less than equal to 4 centimeter without any extrathyroid extension. T3 is classified further classified. T3 is more than 4 centimeter or with minimal extrathyroid extension. T4 is further classified into
extrathyroidal extension.
The minimal extrathyroid extension is when it is including the parathyroidal soft tissue and the striate muscle, that is the sternothyroid.
Okay.
Then T4 is further divided into T4A and T4B. T4A is when there is a gross extrathyroid extension towards involving the other structures, and T4B is involvement of the mediastinal vessels, carotids, encasing the carotids, and the prevertebral fascia involved.
Okay, go ahead.
What would be the cumulative TNM staging of this patient?
Stage 1.
any changes in the cumulative TNM staging in the AGCC8 compared to the previous one?
Yes, sir. The age was changed from 45 years to 55 years recently.
Okay. Right.
So you said you will do, what is the first investigation you will do in this patient?
First investigation I'll do for thyroid function test.
Okay, why do you want to do it first?
So I want to see whether this nodule is hyperfunctioning or a hyperfunctioning or euthyroid nodules.
What is the
Because
significance?
because the euthyroid and when TSH is the euthyroid and hyperfunctioning nodule, the chances of malignancy are higher. And for hyperfunctioning nodule, I'll manage according to the isotope scans.
What did you say about hypofunctioning and malignancy rate being high? Please tell me that again.
I was mentioning that if the TSH is normal, if the patient is euthyroid and TSH is normal, or if TSH is high, sorry, I was wrong. If the TSH is normal or TSH is high, then I'll proceed with USG. Otherwise, if TSH is low, then I'll proceed with the.
You said something about some association with malignancy.
No, ma'am, I was wrong.
Yeah, there's no association. Okay, so don't give that answer at all.
Yes,
There's no known. There used to be previously, they used to say because of fluctuations of TSH, it's not a single TSH value. That's a very old concept. It's fluctuations of TSH, we say, is for multinodular goiters. So there is really no association of TSH. So I would agree with, I have no idea why your TFT is extremely important unless you need to do it. I'm not saying you don't need to do it, but as the first investigation, it's like you write a TFT, then the patient will come back after 1 day with a TFT report, then you will decide. So it's not really, I think it's just something that you write to complete your treatment. If a patient is hyperthyroid, you may have picked it up in your clinical signs and symptoms. You understand? So this is a euthyroid patient clinically. The chances that this patient is going to have a suppressed TSH is going to be very less.
Right.
Right? So TFT really as a go-to first investigation, I wouldn't write it or I wouldn't say it. I don't do that. I definitely ask for a TFT. But that's not what is the first investigation of choice for me when I'm dealing with a solitary thyroid nodule. What would be your first investigation? That's what you should come up with, not none of these. What is your first investigation in a solitary thyroid nodule?
Ultrasound would have been my first investigation for solitary thyroid.
Correct. So it is ultrasound would be, that's the correct answer. If someone asks you what you want to do with a patient who has a solitary thyroid, you want to get an ultrasound. Why do you want to get an ultrasound?
Ma'am, ultrasound is cheap, it's easily available, and because the thyroid is also superficial structure, so ultrasound is very sensitive for picking up any high risk nodule.
Yeah, so I think your answer should be in the other way, that it is probably the most sensitive investigation for differentiating, for understanding the characteristics of the nodule. Cheap, inexpensive can come a little later on.
Okay.
Yeah, so your first thing is that ultrasound has a good sensitivity to understand the characteristics of your nodule.
Okay.
So tell me, what characteristics on the ultrasound will guide you to understand if this is a benign or this is a malignant nodule?
First of all, the consistency of the nodule, then the echogenicity, then
I'll give you a
the.
clue before you start. Okay, when you give this answer, this is the commonest question that will be asked anytime in an exam.
Okay.
When they're asking you what are the features that will tell you benign versus malignant, put the features which have the highest sensitivity for determining benign versus malignant to predict benign as first. Consistency is probably the last feature which is going to tell you that this is benign versus malignant. Go straight for the kill. What is going to tell you that this is benign versus malignant? That's what you're going to look at your ultrasound report. So now think and tell me, what will you think of as benign versus malignant?
The highest features which will predict towards the malignancy will be solid hypoechoic nodule with the irregular margins with taller than wider size, and also the microcalcifications. These are the highest features.
Excellent. Very good. This is how you will answer benign versus malignant. Consistency and all comes later. What is the other thing that will tell you? Any other features you have forgotten?
The vascularity.
Okay. Other than that? Anything? Can you make out extrathyroidal spread?
Yes. Extrathyroidal spread.
Yeah, so you can make out extrathyroidal spread on ultrasound. And one more last feature.
The lateral nodes.
Lateral or central? Any. Lymph node metastasis. Okay, so that completes your whole set of features which are going to suggest benign from malignant. So go ahead. What did the ultrasound show?
The ultrasound findings, the right lobe of the thyroid nodule, there is a well-defined nodule, solid hypoechoic nodule of size of 3.5 by 2.9 by 1.7 centimeter. It's wider than tall. Microcalcifications are present. There is no extrathyroid extension. There is no suspicious cervical lymphadenopathy, and trachea is unremarkable. The left thyroid lobe and the isthmus reveal no nodules.
So what
are
are
these
your...
Sorry.
Yeah, go ahead, Krishna Kumar. Go ahead.
Okay, what are these microcalcifications?
The microcalcifications, these are the hypoechoic structures which are seen in in a hypoechoic nodule, and they usually represent the sum of bodies of the bacterial thyroid carcinomas.
Okay. What other calcifications do you know?
Sorry, sir, I didn't get you.
What other calcifications do you know in thyroid? You know, microcalcifications such as papillary thyroid cancer. So something, any other types of calcifications in thyroid?
Sorry, sir.
Okay, there can be macrocalcifications, there can be punctate calcifications, and so on. Okay. Then, did you say about the vascularity of the nodule? Is that important?
Yes, I maybe missed the vascularity.
So when is that important?
Vascularity is important because the increased vascularity is a feature of follicular thyroid carcinomas.
Okay, and it's not usually seen. May not be a definitive feature of a papillary thyroid cancer.
Yes.
Okay.
Gurpreet, you mentioned solid hypoechoic microcalcifications. You see irregular margins, you will be worried. What are the things on ultrasound, or what are the features of ultrasound that will relieve you, or that will help you say that no, it's probably not a malignant nodule? Any specific description on the ultrasound that you look for?
Cystic nodule or spongiform nodule.
Anything else? So I was talking about calcifications.
A cystic nodule, spongiform nodule with a diffuse enlargement.
So purely cystic nodules, spongiform nodules, as you rightly said, and macrocalcifications are more likely seen in the benign etiology. What are comet tail artifacts?
Comet tail artifacts are actually the hypoechogenicity present behind the hyperechogenicity as a tail. They usually represent the macrocalcifications.
What is it suggestive of?
Not sure.
Colloid nodule.
Colloid nodule.
Yeah.
What are pseudonodules? What are pseudonodules on ultrasound?
Sorry, sir.
Okay. All right. They are seen in autoimmune thyroiditis. Okay. Deposits of lymphocytes. They look like nodules, but they are not actual nodules. Okay. Right. Anything else?
Have you heard of elastography, Gurpreet?
Yes, sir. Elastography
Yeah.
is a recent advancement in the ultrasound of the neck, and
What does it tell you?
the elastography tells about the how hard or firm the nodule is.
Yeah. So it tells us about the consistency. In a hard nodule would more likely point towards a malignancy. In what situations would elastography not help? How do you look for compressibility of a nodule? So basically, the ultrasonologist compresses the probe on the neck and then looks for the anteroposterior compressibility of the nodule. In case there are multiple nodules in the anteroposterior direction, one might not be able to judge the compressibility of one nodule over the other. So in such a situation, elastography might not help you.
Okay.
What's thyroid's classification?
Uh,
Thyroid staging system.
Thyroids is a thyroid imaging, reporting, and analysis and data system. Thyroids is basically uniformed reporting, is used for the uniform reporting of the
What are the subsections in it?
subsections. Include first the consistency, ecogenicity, then the margins, then ecogenic foci, then
Is it useful?
yes, ma'am. With the help of thyroids, we can suspect the possibility of malignancy of a particular nodule.
So what are your indications for FNAC? The ATA gives us indications for FNAC. What are your indications for performing an FNAC? Is thyroids there in the ATA indications for FNAC?
No, ma'am. Thyroids is not mentioned in
Not mentioned. So
ATA.
what are your indications?
As per ATA, the indications are any nodule, any solid hypoechoic nodule more than 1 centimeter, and any a solid hypoechoic more than 1 centimeter, spongiform nodule more than 1.5 centimeter, and according to the ATA, they have further classified the ultrasonic features into very low, low, intermediate, and high. Benign, very low, low, intermediate, and high risk. And in high risk, any nodule more than 1 centimeter, it should be FNEC.
Correct.
And for
Multinodular goiter then?
multinodular goiter, you have to FNAC any high risk nodule if you found over the ultrasound.
If no high risk, then do we need to FNAC?
For
Do they have a
multinodular
recommendation?
goiter, ma'am, only for the high risk nodule we go for the FNAC.
So they say two things. So yeah, high risk nodule definitely a poor grade of recommendation, but they say any nodule that's more than 4 centimeters, you must FNA even if you have a multinodular goiter. Yeah. Okay, when will
So
you ask for a CT scan in any patient with a thyroid nodule?
CT scan if you are suspecting any invasion, or if T3 or T4 nodule is there, to look for any distant metastasis or any cervical lymphadenopathy. And yes, ma'am.
1 minute. I think you've gone too fast. For a T3 nodule, you'll ask for a CT scan? What are your indications of doing a CT scan in patients with thyroid cancer? Let's say you've got FNAC, papillary thyroid cancer. When will you order? You've done an ultrasound, you've got an FNAC. When will you order a CT scan? Tell me the indications.
The indications are any suspected invasion.
Tell me, what is the suspected? How do you suspect this invasion?
If my thyroid nodule is fixed to the underlying structures or the skin or the straps, or if there is a change of voice or any breathing difficulty, or it's a huge thyroid with the compressive symptoms, or the retrosternal extension I'm suspecting, these are the indications.
Okay, so you have said on history and clinical examination, if you find this is an aggressive tumor, then you will do it. Any other indications?
Look for the central compartment. Also, CT is more sensitive than USG.
So in this patient, will you do a CT scan? This patient has no suspicious cervical lymphadenopathy, has a 3.5 centimeter nodule. Do you want to do a CT scan? You just said central compartment is more sensitive.
No, ma'am. For this patient, I will not go for the CT scan.
Then what is the role of CT scan for picking up central compartment nodes if you don't go in for this patient? Then in which patient do you want to do? Those big patients, it doesn't matter. Aggressive tumors, you will be doing central compartment dissection in all those patients. With those T3, T4, all of that you said, unable to get below, you will be doing.
Also in bulky nodes, bulky nodal disease also I go for a CT scan.
Excellent. In that you'll go. I'm talking about a N0 neck. You said no, central compartment is highly sensitive. So
Yes.
actually, if you want to do a CT scan for central compartment lymphadenopathy, this is the patient you have to do it for. Okay, in which you don't see central compartment lymph nodes. It's an early lesion. You're unsure during your surgery what you want to do for this patient. If at all you want to do, it's not recommended. So I agree with you that even I won't do it for this. But if at all you want to see it for the central compartment, it is this group of patients that you need to do the CT scan for. Any issues with the contrast in CT scan causing an issue postoperatively?
Some iodinated contrasts actually are avoided, as it may cause the post-operative radioactive iodine management delay for around 1 to 2 months.
1 to 2 months, is it? So let's say today you do the CT scan with iodinated contrast. When can you do the radioactive iodine scan?
After 1 month.
So is that a problem? Today you do the scan, tomorrow you will operate the patient. Then you'll have to give some time for the patient to become hypothyroid.
No problem. We can go ahead with the contrast CT.
So when is it a problem? Any scenario where it is a problem that you cannot use iodinated contrast. Don't tell me reaction to iodinated contrast, that I know. It's important to understand that, because I think we have to keep our mind open for doing things like recombinant TSH.
Yes,
So if you're planning, especially in this low risk patient, if you're planning a recombinant TSH based hypothyroidism post surgery and not letting the patient become hypothyroid for 3-4 weeks, in that group of patients you will not. So if you have someone who cannot tolerate hypothyroidism and may require a radioactive iodine scan, that's the only indication where you don't need to do, you cannot do a CT scan preoperatively with iodinated contrast. Okay, but all of that generally doesn't happen. It's a very rare situation, but if you want to do it, that's the only situation where you don't require. Otherwise, iodinated contrast within 3 to 4 weeks after doing it gets washed away and does not cause a problem with a radioactive iodine. Okay, go ahead.
On FNAC, the FNAC is suggestive of papillary thyroid carcinoma, and that is a category 6. Summary, she's a 30-year-old female with the papillary carcinoma of thyroid, clinically T2 and 090. Patient is euthyroid and without any blemishes.
So one question, how do you do FNAC?
FNAC is done with the help of 25 to 27 gauge needles, sir, with 5 to 10 cc syringe and multiple, preferably without any suction, and it's 25 to 27 gauge needle.
Will some imaging help?
Yeah, ultrasound guided it should be preferable.
Why do you want to do an ultrasound guidance?
It improves the
What did you say? Sorry.
sorry, sir.
Why do you want an ultrasound guidance? I didn't get that.
It avoids the negative aspirations, and also the high risk nodule can be targeted, sir, and any solid hypoechoic nodule can be targeted.
Okay, solid areas. Look for solid areas. Okay, there can be cystic areas. And what are the categories? So what do you know about categorization on FNAC?
This is a Bethesda-based system with 6 categories in it. Bethesda 1 is non-diagnostic. Bethesda 2 is benign. Bethesda 3 is atypia of unknown.
What is this non-diagnostic category?
Because the smear is not adequate, or
When do you say that?
not
It is-
representative.
Mhm.
Either it is not adequate or it is non-representative.
Now, is there any criteria for the pathologist to say that it is not?
From 6 clusters of around 10 to 15 follicles in each cluster should be used.
All right. Okay, proceed. What are the other categories?
Other categories, the category 3 is atypia of unknown significance or follicular lesion of unknown significance. The category 4 is follicular neoplasm. Category 5 is suspicious of malignancy, and category 6 is malignancy.
And what is the relevance of all this categorization?
With the help of this categorization, we can suspect the possible malignancy, and we can plan our management or the surveillance.
Great. Is there any recent change to this categorization?
There is involvement of NIFTP into the benign, and after shifting the NIFTP into the benign, we have actually reduced the overall malignancy rates in the different categories.
Great. Fine. Go ahead.
Who described this NIFTP? You know any names? Any publications?
Don't remember.
You should read about it.
Yes, ma'am.
Go ahead. What will you do for this patient?
I'll go for the hemithyroidectomy for this patient.
Do you want to discuss with the patient, or you will just take the patient and decide whatever you want for yourself?
I'll counsel the patient, and also I'll take consent for the possibility of total thyroidectomy, along with the all the complications I'll explain, and will return with written consent of converting into total thyroidectomy with the lateral neck dissection. So not lateral, total thyroidectomy with the different complications. I'll proceed with the surgery.
So tell me, how will you counsel this patient? I think you mustn't, any case that you want to do, and this is important for practice also. Always the counseling of the patient is extremely important, and it's not just for telling them about that you may have a second surgery. That's not the counseling that you need to do. So tell me, what all will you counsel a patient for when you're considering a 3 centimeter nodule for a hemithyroidectomy? What does your counseling? Yes, second surgery we can discuss. Besides that, is there anything else that you need to counsel this young lady of 30 years old? What all will you counsel for her? What are the pros and cons that you will explain to your patient when you are thinking of hemi versus total?
For the pros part, uh, in a in favor of hemithyrectomy, I can explain that there is no need of or there is lesser chances of post-operative thyroxine supplementation, and also lesser
What
chance of
percentage of patients after hemithyroidectomy require calcium thyroid hormone supplementation?
rarely percentage. I don't know.
So then you can't counsel the patient if you don't know the percentage. So you cannot put this patient onto your table for doing a hemithyroidectomy without telling the patient all of this. Okay, so it's a very high percentage of patients. What is important about the thyroid supplementation that you can tell them as a pro?
That the requirement will be lesser than the total hysterectomy.
Correct. So a large percentage of patients require thyroid supplementation even after. So otherwise, what happens is you'll do a hemi for this patient, and in the post-op after 3 weeks or after 1 month, you'll start the patient on L-troxin supplementation. And patient will say, then why you told me that I don't require a. So you have to know the percentages to be able to answer your patient. You have to be able to tell the patient this much percent may still require, but your dosage will be less. How does that make a difference to the patient? The patient's going to take a tablet. How does it make if she's taking 25, 50, 75 or 800? How does it make a difference to the patient? Taking lower doses of L-troxin. Is there any side effects of long-term usage of L-troxin?
Yes, ma'am.
Will this patient require long-term L-troxin?
Yes, for long-term uses of L-troxin,
Especially in females?
cardiac complications and the chances of the
Okay, so osteoporosis, it can lead to osteoporosis. Okay, so which is why it is important. So when you're counseling, what you need to say is that you may require lesser dosages, but if you have lesser dosages, the chances of you developing osteoporosis is less, and that's why we want to do your hemithyroidectomy. Okay, so that's your first reason. Second reason,
the chances of hypocalcemia and the nerve injury are also lesser.
okay, so chances of hypocalcemia, nerve injury lesser. Very good. Anything else?
And
Okay, tell me what are the disadvantages that you will tell the patient of doing a hemithyroidectomy?
first of all, if in post-operative period any recurrence is there, or if opposite gland is involved, or there is a new nodule in the opposite gland, we may require the repeat surgery. And repeat
What
surgery,
are indications for repeat surgery?
one, if there is any recurrence or a residual disease.
How will you get a recurrence or a residual disease within 6 weeks? Repeat surgery, you mean recurrence and residual disease after maybe after 2 years or 6 months? So what is the incidence of recurrence after a hemithyroidectomy? And quote the paper for it.
There is Billy Moria et al. Paper which has mentioned the lobectomy versus total thyroidectomy. They have analyzed almost around 50,000 patients with 9,000 lobectomies, and they analyzed that the chances of recurrences are 7.1% in lobectomy versus 9.8% in total. sorry, 7.1% in protonectomy versus 9.8% in lobectomies.
So is that a big difference?
No.
So would that be your first reason to tell the patient that that is the reason why you should not be undergoing a hemithyroidectomy?
Second reason can be that
First reason is only not, this is not the correct reason, because see, the chances of recurrence, if in a well selected patient like this, the chances of recurrence, actually Bilimoria's paper was a hodgepodge of a whole lot of cases. But if you look at other series of hemithyroidectomy, the recurrence rates are less than 1 to 2%.
yes.
Very low, less than 5%, all recurrence rates, except for Ian Hayes' paper, which was a very old paper. All recurrence rates are very low. So you can't scare the patient into saying don't do a hemithyroidectomy by saying that you will require a second surgery for recurrence.
Other reason can be the post-op surveillance of the patient with the help of thyroid globulin is not possible if I go with the lobectomy.
So that's a good reason. Any other reasons?
Or any residual disease is there, then radioactive iodine can also be difficult to ablate the remaining disease.
This is the most basic question. You should prepare this very well. Okay, this is an absolutely basic question of what are the advantages and disadvantages. And this you will see every day. It's not just for your exam. When you're talking to a patient for a hemi versus a total, you need to know this much better. Okay? So read the indications and what is the advantages of doing a hemi and what are the advantages of doing a total.
Okay, so you said you're going to do a hemithyroidectomy in a 3 centimeter nodule, right?
Yes.
FNAC was?
Papillary thyroid, BAT 6.
BAT 6. Okay, so what are the definitive indications of a hemithyroidectomy?
The less than
When you
thyroid microcarcinomas without any invasion. T1A lesions without any invasion.
Okay, so less than 1 centimeter nodules without extrathyroidal extension, no clinical nodes, unifocal, and probably no history of family history and so on. So, what are the definitive indications for total thyroidectomy?
Any extrathyroidal extension and N plus disease and T N plus disease and T3, T4 lesion and N plus disease.
Anything else? Any size criteria?
More than 4 centimeters.
Anything else? Any clinical finding? If you have a node, a clinically positive node, you may consider you will do a total thyroidectomy.
Yes.
And anything on ultrasound?
On ultrasound, if along with the solid hypoechoic nodule, any other high-risk feature like irregular margins or the microcalcifications are present, it becomes the disease and also the extrathyroidal extension becomes disease more aggressive.
When the ultrasound shows there are contralateral nodules, okay. Okay, then you can consider total thyroidectomy. So, in a 1 to 4 centimeter nodule, when will you consider? When will you do a total thyroidectomy?
In 1 to 4 centimeter nodule, also if nodal disease is present, then I'll go for the total thyroidectomy. And also, if extrathyroidal extension is there in 1 to 4 centimeter, I'll go for total thyroidectomy.
No, without
anything in the history, Gurpreet? Anything, any factors in history that will help you take a decision regarding hemi versus total in this subgroup of patients?
Yes, sir. Radiation exposure of extremes of ages, I will go for the total thyroidectomy.
So that's correct. When there is a history of family history of radiotherapy, family history of thyroid cancer, history of radiotherapy and when age is more than 55. That's what ATA says. Okay. Right.
Even gender, just to add to that list, even gender, males are is a poor prognostic factor. So even that will add on to your decision.
Male patients.
So when do you do a completion thyroidectomy?
Completion thyroidectomy, if, after hemithyroidectomy or the lobectomy, if extrathyroidal extension was reported in the later final HPR, or if any central compartment node which was found positive after final HPR, then also I'll proceed with the completion thyroidectomy. And or the nodule is more than 4 centimeter on the final HPR.
And why do you want to do completion thyroidectomy?
For the surveillance over the thyroglobulins, for the post-op surveillance, and also for the feasibility of radioactive iodine therapies.
Okay. So completion thyroidectomy is done when when a diagnosis of malignancy is made following lobectomy. Sometimes we are not sure, like in a Bethesda 3 or 4, and if it is a bigger nodule, and then the presence of aggressive pathological features. Okay. So what are these aggressive pathological features?
Aggressive pathological features, including the tall cell variant, columnar variant, Hobnell variant, or the poorly differentiated variants.
Those are the variants. Any other histological characteristics?
Histological characteristics, the
vascular aggressive vascular
vascular
invasions. Okay. And maybe ipsilateral multifocality sometimes. Okay, so these are the indications of completion thyroidectomy. Any other questions from your side, Shikhar?
Yes, sir. Gurpreet, are you aware of any incidence or percentage of times you'll have aggressive features on histopathology wherein you have to go in for a completion thyroidectomy after you've done a lobectomy? How many times will that happen? Are you aware of any number or any paper?
No, sir, sorry.
So actually that paper has recently come out from the Amrita group itself. Around 60% of the times they found features on histology wherein they had to go in and do a completion thyroidectomy after lobectomy was performed, or they found aggressive histologies after lobectomy was performed. It was 59% in that Amrita paper.
Okay.
So read that up. Yeah.
Sure.
What is lobar ablation?
Lobar ablation.
What is lobar ablation?
So, I'm not sure. The radioactive iodine after the hemithyroidectomy is.
Yeah. So without doing a completion thyroidectomy, when you ablate the remaining lobe, suppose if the patient is not willing for that surgery,
Yes.
that can be considered, but that's not usually practiced. But there are papers, little old papers describing lobar ablation. Okay. Right. So what did you do in this case?
I'll proceed with the hemithyroidectomy for this patient after explaining and after taking due consents.
So I'll ask you some practical surgical questions. How will you find the superior laryngeal nerve when you do a thyroidectomy?
For superior laryngeal nerve, I'll find in the Barry's triangle. Barry's triangle, which is composed of Joel's triangle, which is composed of strap muscles inserting in the insertion of strap muscles superiorly, with the superior pole and the vessels and superior thyroid pedicle in the lateral part, and also the medial part is also composed of the step muscle, and superior laryngeal nerve lies in the bed.
So what muscle is there on the medial aspect?
Cricothyroids.
Cricothyroid muscles. And what is Cernia's classification?
Cernia classification is basically the various types of superior laryngeal nerve in relation to the superior pole of the thyroid. Is classifying among type 1, type 2A, type 2B, and type 3.
What is type 2B?
Type 2B.
Is there a type C? Is there a type C?
Type 3 is recently explained type when the superior laryngeal nerve, rather than passing ventrally, it is passing dorsally.
Okay.
Is
Alright.
that part of Cernia or is that part of some other classification?
This is a modification, sir. Forgot the name. It's a modifications. I don't remember.
So the classical Cernia classification doesn't have type 3.
Yes, sir. Classical Cernia is only 1, 2A, and 2B.
Excuse me, just a minute, sir. So we also need to have the Pavitra's lecture.
Yeah.
So can we wind up in the next 2 minutes?
Oh, sure. So for you, question, while doing surgery, you find that your nerve is cut. Okay. What will you do?
Sir, there are few options. If the nerve is cut, we may do an anastomosis, end-to-end anastomosis, or we may proceed with the cable grafts, or we may proceed with the nerve muscle transfers.
Okay. What is the purpose of all this?
The purpose of all this is to maintain the tone of the cricothyroid muscles.
Very good. Right. Any other questions, Chika?
Yes. So Gurpreet, just to how would you identify the parathyroid? What steps would you take to preserve your parathyroids?
First of all, I'll always aim towards my capsule while dissecting the thyroid off. Right. Second, while ligating the inferior thyroid artery, I'll be closer to the gland rather than being far away. And also, while doing the central.
How would you identify? How would you identify landmarks?
Landmarks are one for the superior. That is the superior thyroid parathyroid gland is the vertex gland. It is more posterior. Superior parathyroid gland is more posterior in the from the vertex gland. That is the plane of both the RLNs. So while dissecting and while finding the plane of RLN, the superior thyroid, the parathyroids can be more dorsal, and inferior parathyroids are more ventral, and also towards the tubercle of Zucker-Candle can also be a landmark for both the RLN and the superior parathyroid. So
you take a coronal plane of the nerve. Yes, your superior parathyroid will be dorsal, and the inferior parathyroid to be ventral and inferior. Okay. Yes. How is inferior parathyroid in relation to the inferior thyroid artery?
In relation to the inferior thyroid artery, the inferior parathyroids are more lateral and also receiving a branch from inferior thyroid arteries.
All right. Anything else?
I think we have run out of time, sir.
No problems. I think we
need to have we need to start the lecture also.
So you presented well, but I feel you should increase your reading a little more so that you are confident with your answers.
Yes.
Thank you.
Thank you, ma'am.
Thank you, Dr. Krishna Kumar sir.
Yeah.
Thank you, Shikhar. I think Gauri madam has left. And thank you, Gurpreet. I'd like to invite Dr. Pavitra Shanmugam. She is a consultant head and neck surgeon at Apollo Proton Cancer, Chennai. She'll be speaking on role of central compartment resection in a differentiated thyroid cancer.
Thank you, Dr. Asim sir and Dr. Ravi sir for giving me this opportunity. I will be speaking about the role of central compartment clearance in DTC. Is my screen visible, sir?
Yeah, it is visible.
Okay. First of all, happy Onam all. And my presentation starts with introduction. And I will be reiterating the points what we have discussed earlier. So papillary thyroid carcinoma is the most common thyroid malignancy with an incidence of 85% and more predilection for lymph node metastasis. And lymph node metastasis in the central compartment is the most common site and which accounts for around 20 to 50%. And even if the micrometastases are included in the HPR, then the incidence rises up to 90%. And it can cause skip metastasis in case of superior pole thyroid tumors. And there is clear consensus supporting the therapeutic central compartment clearance for clinically apparent nodal diseases. And the question here is the role of prophylactic or elective central compartment clearance in early DTC. Incidence of lymph node metastasis in papillary thyroid carcinoma more than 1 centimeter, it is around 50 to 75%. And in micropapillary thyroid cancers, it is around 25 to 50%. Ipsilateral central compartment is around 25 to 60%. Contralateral mets involves around 10 to 30%. The controversies we need to discuss is around questionable benefit of elective or prophylactic central compartment clearance in clinico-radiologically node negative disease, when to do, whether it is elective or therapeutic, the sensitivity of various modalities. Risk factors for the central lymph node metastasis in clinically node negative thyroid disease is discussed in systematic review meta-analysis by Busan and Liu involving various studies. And these factors include age less than 45 years, male gender, multifocality, size more than 2 centimeter, capsular invasion, lymphovascular invasion. Definitions: prophylactic central compartment clearance, removal of the central compartment lymph nodes in the absence of clinical involvement or radiologically, and even includes the intraoperative assessment of the central compartment. And therapeutic is, as we know, if the patient is having clinico-radiological lymph nodes, which can be, should be included at the time of total thyroidectomy. Bilateral central compartment neck dissection and ipsilateral central compartment neck dissection. Lymph nodes from the hyoid bone to the innominate artery on the right side and associated level on the left side to the medial border of the common carotid artery and lymph nodes posterior to the recurrent laryngeal nerves is bilateral central compartment neck dissection. Ipsilateral involves till the midline pretracheal and pre-laryngeal lymph nodes. Redefining classification of the central neck dissection defines the terminology, various terminologies like paratracheal node sampling, paratracheal node dissection, and comprehensive central neck dissection, where it includes nodes from the cricoid cartilage superiorly to the innominate artery, inferiorly, and also nodes including lateral and medial to the RLN. Surgical anatomy, which includes level 6 and 7. The boundaries include superiorly hyoid bone, laterally carotid sheath, anteriorly superior layer of deep cervical fascia, posteriorly prevertebral layer of deep cervical fascia, inferiorly innominate artery on the right side and associated level on the left side. Anatomical location, we have area A, B, D, and C. A is prelaryngeal Delphian node, B on the right side paratracheal, D is on the left side paratracheal, C is subischemic pretracheal lesions. Recurrent laryngeal nerve, right side recurrent laryngeal nerve is oblique and more ventral, which divides central compartment into lower medial and upper lateral triangle. And that's why we need to dissect even posteriorly to the right side. So the 360-degree clearance is needed on the right side, and left side it is more vertical and it is in the tracheoesophageal grooves, dividing the left central compartment into anterior and posterior. Preoperative evaluation of clinically node negative disease involves ultrasonography. In this study, they have included ultrasonography to decide whether it is clinically node negative, and they did elective central compartment neck dissection and pathologically analyzed those lymph nodes and found the incidence around 30 to 60%, thereby giving the sensitivity of around 30 to 80% and specificity 95 to 97%. This is the sensitivity of imaging in central compartment from the various studies, including ultrasonography and CT scan, ranging from 30 to 40%. Rationale for the prophylactic central compartment node dissection in various studies includes a few recommendations when the patients have these higher risk factors, including 2 or more of higher risk factors like male, gender, age more than 55, maximum tumor size of more than 3 centimeter, and massive ETE. Surgical technique is described in Robbins et al. And ATA 2009, but superior limit of central compartment clearance is still debatable. Level of superior thyroid artery or thyroid cartilage or at the level of cricoid cartilage were discussed in various studies. Key steps in central compartment node dissection. We have to dissect prelaryngeal nodes, pretracheal nodes, and paratracheal dissection. Recommendations given according to ATA guidelines is 2015, when we have to consider for a prophylactic, when we should not consider for a central compartment neck dissection electively is when the lesion is small T1, T2, non-invasive or node negative. But in British Thyroid Association, it is given as the personalized decision may be made based on the risk factors, which includes adverse histology, age more than 45 years, ETE present, multilocal disease, and tumor size more than 4 centimeter. So we'll be discussing the pros and cons of central compartment clearance. So pros, as already discussed, complete clearance of the disease may lower the post-operative TG levels, reducing the chances of recurrence and the morbidities of reoperations, and provides notes for the exact nodal staging and prognosticate the patient. Cons, which includes the upstaging of the disease, increasing the RAI misuse, and increased risk of hypoparathyroidism. Outcomes of central compartment neck dissection as per meta-analysis. The recurrence and hypocalcemia are significant. The take-home message, which includes the various guidelines, and NCC guidelines strongly recommend prophylactic central compartment clearance in T3, T4 with risk of post-op hypoparathyroidism and RLN injury. and Japanese Society of Thyroid Cancer Surgeons, they routinely practice this prophylactic central compartment neck dissection when but the rest of the world where elective central compartment neck dissection is considered is T3, T4 and the high risk features and the presence of lateral neck metastasis. These are my references. Thank you.
Thank you, Dr. Pavitra, for such a nice presentation. And with this, we conclude our session. I think Dr. Gauri Pantvaidya Madam and Dr. Shikhar Sani have signed out already. Krishna Kumar sir, thank you so much for taking out time. Thank you, sir. Sir, final words from you. Okay, I think sir is also signed out. Thank you so much, all the participants. Thank you, Dr. Gurpreet. Hopefully, we'll see you again after 15 days with a new topic and a new presenter. Thank you so much.